So this slide also shows you, in addition, the C-peptide response is lower at the 2-hour time point using insulin aspart, which is very nice because the insulin works now for the food and is gone between the meals, so it doesn't force feed the women to feel hungry and eat more than they should. So what about the long-acting insulin analogs? There has never been a clinical trial, a randomized clinical trial using insulin glargine, and the brand name for that is Lantus. Even though there are case reports, the total number of cases ever documented are 219. To prove the null hypothesis that an insulin does not cause a problem takes over 500 pregnancies. So we don't know whether insulin glargine is safe, but the truth is the studies have not been published to be able to say that insulin glargine can be used. However, most recently, insulin dedamer has been given category B in the United States, which is spectacular. And the reason I say that is that to give NPH insulin as your basal means the women have to wait up until midnight, because NPH is only an 8-hour insulin. So they have to take NPH every 8 hours. They have to wake up very late to take their last dose of dedamer, their last dose of NPH. It's wonderful now to have a study that shows you can take insulin dedamer twice a day, and it actually has a better outcome than using NPH as your basal insulin. And these papers have just recently been published by Elizabeth Mathieson and Professor Hood, and so you can do a PubMed search on insulin dedamer, and you will see it truly is an elegant insulin and is a category B, which means it's approved safety in pregnancy. So here is what we use, because it's cheaper out of county, to give NPH every 8 hours, and then use either aspart or lispro before each and every meal. But wouldn't it be wonderful if we could use an insulin pump? The problem is an insulin pump is expensive, and the types of insulins that go into insulin pumps have to be approved in pregnancy, which means you could only use insulin aspart or insulin lispro in the pump, but we're also talking about a device that could malfunction. So it may not be as safe as using multiple injections. But this is the protocol that we use for those women who are on insulin pumps. We increase and decrease the basal infusion rate based on their needs for their dawn phenomenon, their basal need for exercise, for stress, and then push the button each and every time they eat. But how about glucose sensors? Well, nobody knows whether using a continuous glucose monitor will help or hurt a pregnant woman. And the reason I say that is that if indeed the monitor is not accurate and the numbers are wrong on the glucose sensor, then the doctor and the patient may never know that things are going the wrong direction. So there's now a huge clinical trial going on looking at the safety and efficacy of continuous glucose monitors versus intermittent blood glucose checks. But the first study that was published was actually ours, because I tried to say to, actually it was Medtronic, there was no reason that I needed to use a glucose sensor. But the truth is I was asking my women to measure their blood sugar before and 1 hour after eating, shown to you in the boxes. So they were doing exactly as I said. They were measuring their blood sugar before and after breakfast, eating a teeny tiny breakfast, and then they'd go eat. And they'd measure their blood sugar before and after lunch, and then they'd go eat. They would measure their blood sugar before and after dinner, and then they would go eat. So I had no idea there were so many times during the day that their blood sugars were elevated. So here I want to show you that in the 10 patients that we reported that I thought were in good control because they were doing blood sugars before and after meals, how often they had blood sugars greater than 120. The time spent with a blood sugar greater than 120 was up to 2 to 3 hours a day, and therefore continuous glucose monitoring truly probably has a place in the treatment of diabetes in pregnancy, and the monitors have become more accurate. And that's why the Juvenile Diabetes Foundation has funded a trial to look at the safety and efficacy of using a continuous glucose monitor. But I want to show you that the monitors actually identify the peaks. This is a slide showing you clearly that doing lots of blood sugars in the red dots, tells you you're in the normal range, but also it is accurate to identify where the peaks are, so that these unknown peaks that may occur in the middle of the night, or if a woman has a birthday party and she didn't check her blood sugar after eating cake, it really is nice to have the glucose sensor be more accurate. But the last question I'm going to leave you with is, why do some diabetic women who have normal weight infants have normal weight infants, even though we know their blood sugars were terrible? Well, there are 10 reasons that babies are growth restricted and 10 reasons why babies are overgrown. So it could be the reason a baby is normal birth weight despite having hyperglycemia on the maternal side is that she has one of these or two of those, or a combination of one or both. But all of our women live at sea level, so certainly is an altitude making them decrease their macrosomia. And certainly it has nothing to do with smoking, because most of my women don't smoke in California. But it's actually the baby. The baby is an accomplice in its own destiny. Very sluggish babies get fatter than babies that are very active. So we did studies designed to prove the fidgety fetus hypothesis, that the babies that wiggle around more are the babies who stay the smallest. So we did heart rate monitoring as a surrogate marker for fetal activity. And the heart rate will go up when the baby is kicking a lot. So we were using these surrogate markers for fetal activity, and you can clearly see that the macrosomic infants, those babies that were greater than the 90th percentile, were the babies that were sluggish. And the mothers knew that. They'd say, the baby doesn't move much, it doesn't kick much. Those are the babies at the highest risk for being macrosomic. The babies that are hyperactive actually tolerate hyperglycemia more because they themselves are utilizing the extra glucose the mother may have in her bloodstream. So now I leave you with only an opinion from Santa Barbara, California. Now, we are the most gorgeous place in the world, so of course we're right. And the answer to the question is, how do you have the best possible baby, is that normal glycemia before, during, and after all pregnancies complicated by diabetes results in a normal baby. Thank you very much.